So very good morning everyone. Today we are going to discuss about asthma. So asthma is the one of the respiratory disorders which is affecting millions of people worldwide. So it's a respiratory disorder. Asthma is a respiratory disorder which is characterized by bronchoconstrictions. Your bronchi will be constrict. So which is characterized by bronchoconstrictions. And due to bronchoconstrictions, patients will feel difficulty in breathing. So there is a difficulty in breathing. Difficulty in breathing. And this asthma we also call that it's a hyper responsiveness of bronchi due to stimuli. So stimuli can be your dust, stimuli can be your pollen, stimuli can be your environmental factors, pollution, smoking and so on. So whenever you have to define the asthma, you can define it in multiple ways. Asthma is a respiratory disorder in which bronchoconstrictions happens and characterized by difficulty in breathing, which is triggered by various agents like pollen, like dust, like environmental factor, like pollutions and so on. So next is risk factors. When we talk about etiology or risk factors of the asthma, is there is a genetic factors. I told you in every disease, in most of the disease, there are a genetic factor as well as environmental factors play a major role in the involvement of disease. Environmental factors. So genetic factors, when in families there is someone having a asthma, so if that environmental factor is triggered by so their environmental factors when interact with particular that genetic makeup, it will result in development of disease. So that's why we call it, it's a means etiology, exact etiology is unknown, but of course genetic factors and environmental factors play an important role in the development of this disease. And risk factors, like if someone having allergic to pollen, someone can be sensitive to dust, cockroach, mites, pollutions, smoking. So these all are the risk factors, and someone having that particular genetic makeup and that person is exposing to pollen, dust mite, pollution, smoking, so there is a chances of asthma. So these could result in the development of bronchoconstrictions, and due to bronchoconstrictions the patients can feel difficulty in breathing. So that is your risk factors. Now if we move types of asthma, so there is a acute asthma and chronic asthma. So I told you what is the difference between acute and chronic. Acute means if you have a asthmatic attack for a smaller period of time, so that we call acute asthma. If someone is suffering for a longer period of time, that we call chronic asthma. So that are the different types of asthma. So most importantly now is pathogenesis. How someone is become more sensitive to pollen, more sensitive to dust, more sensitive to particular matters. So how it happens? So that is very important part, and that is pathogenesis. So pathogenesis of asthma. And of course, I told you when you are writing the pathophysiology of disease, you have to write the definitions, you have to write the etiology, you have to write the epidemiology as well. So epidemiology means how many populations are affecting from the asthma. So millions of people across the globe are affecting from the asthma, and it's not a age specific disease. Like there are many diseases which are age specific, like Alzheimer disease. Alzheimer disease, you can't see the cases of Alzheimer in children, but asthma can happen at any age. You can see that in many children who are school ongoing, so they are also suffering from asthmatic attack, they are also getting the asthmatic attack. So it's not a age specific disease, it can happen at any age. It can happen to male as well as female as well. It's not gender specific. So that things you have to write in the epidemiology sections. Now pathogenesis. Now question is how someone will become more sensitive to particular agents. Like if we talk about pollen or dust mites or anything, so what happens whenever whenever pollen, dust mites, anything enter in your body? So I told many times what will happen. So first thing is your immune systems will detect it, right? So immune systems the immune cells which are present in the circulation is WBC, white blood cells. So first, the major functions of the immune cell is to detect the differences between self and non-self proteins. So when pollen is of course it's a exogenous substance. So your immune system will detect it as a exogenous substance. So how detection will happen? I told you there is every exogenous substances have specialized proteins on their surfaces, and that we call PAMP as well. PAMP, pathogen associated molecular patterns. So there is a particular patterns. Not only pollens is going to result in asthma, or your bacterial agents can also induce the asthma. Bacterial infections, recurrent infection can also result in bronchoconstrictions. So these will be sensed. I told you there are sensors on your immune cells. Sensor proteins are there on the immune cells, and that we call PRR. PRR stands for pattern recognition receptors. So PRR is pattern recognition receptors. So as its name indicate, what is their purpose? Pattern recognition receptors will recognize specific patterns which is not of self molecules or self endogenous molecules. Pattern is not that. So they are going to recognize particular pattern, and that pattern is PAMP, that is not of your body pattern. So their purpose is to sense it, whether it is a self or non-self. That is the first functions of immune cells. So in this case also your WBC will recognize pollen as a non-self. If it categorizing as a self, so nothing will be going to activate. So pollen is not your dust mite is not your exogenous endogenous substance. So your immune cells will recognize it as a non-self molecules, and under PRR there is I told you there is a TLR, toll-like receptors is one of the PRR, and there are many toll-like receptor 1, 2, 11, 12 toll-like receptor, TLR 1, 2, 3, 4, and particular part of the particular type of the toll-like receptor will sense particular part of the pathogens, like some are sensing bacteria, some are sensing viral pathogens, and so on. Then there is a node-like receptors as well, that is also under category of PRR. So what will happen? These will sense pollen as a exogenous substance. If suppose there are 100 students goes to the garden and they exposed to the pollen. So in all their body, what's going on when you are exposed to the pollen? So what will happen? Your WBC will sense it exogenous substances, and WBC will engulf that pollen. It will engulf the pollen inside the WBCs. So your pollen will be engulfed. But how engulfment will be done? Engulfment will not start if your WBC will not sense it a non-self molecules. If WBC is unable to sense it, so WBC will not engulf that pathogens or that particular exogenous substances. So in this case, suppose 200 students went to the gardens and they exposed to the pollen. So in their bodies, what reaction is going on? Pollen will be detected as a exogenous substance, and WBC will engulf it, and that process we call endocytosis. I hope you know there are two processes, endocytosis and exocytosis. Endocytosis is a process by which your exogenous molecules will enter from outside to inside the cells. That is your endocytosis. Exocytosis is inverse of it. Exocytosis means there is a movement of molecules from inside to cells to outside. The classical example of exocytosis is release of neurotransmitters. So neurotransmitters are stored inside the neurons in the vesicles like adrenaline, non-adrenaline, acetylcholine. So whenever stimulus is generated, these vesicles will diffuse with the membrane, and whatever the chemical stored inside the vesicle, it will goes outside. So that is the example of exocytosis, classical example. But in this case, what is happening? It's a endocytosis. Means the exogenous substances are engulfed by the WBC. So your molecule is going to enter from outside to inside. So that's why this process we call endocytosis. So now when it engulf it, it will diffuse with your vesicles, it will form the phagolysosome, and these enzymes, these chemicals will destroy that pollen, and your pollen will be destroyed by the WBC. That will happen in the individuals, means whatever as I said, means 200 students goes to the garden. So in the body, these reaction is happening and nothing is happens, right? Nothing is happened clinically. So they are exposed to the pollen, WBC detected, WBC phagocytosized it and killed it, right? But unfortunately, for example, out of 200 students, there are 10 students in which these signalings will further activated. Their WBC is not going to do the killing of pollens, but they are going to activate adaptive immune signaling pathway, but only in 10 individuals. For example, these are unfortunate, so these reaction is going to start. So that reactions, what will happen in that reactions? In that reactions, your WBC will hand over that pollen to adaptive immune system, which is not required. But because in their bodies, these reactions will happen, and they are going to be become sensitive, unless and until they are not still not become the sensitive to the pollen. But there in their body, all the reaction is going to start. So these undesired reaction, what is happening? These WBC catch that pollen. So this is pollen. It catch that pollen and present it to the cytotoxic T cells. TC. I told you there are majorly we are categorizing the T cell into 3 category: helper T cell, cytotoxic T cell, regulatory T cell. So this WBC will present this pollen proteins to these cytotoxic T cells. So how these presentations will happen? So I told you earlier as well, this presentation is very specialized mechanisms. There are MHC molecules which helps in the presentations of these chemical to the adaptive immune system. So MHC is of 2 types, right? MHC1 and MHC2. So if your antigen is your exogenous substance is catched by MHC2, then it will always present to the helper T cells. But in this case, your pollen or your dust mite is going to present to cytotoxic T cells. So in this case, your antigen will be catched by MHC1, not MHC2, MHC1. So this MHC1 molecule, MHC stands for major histocompatibility complex. So this major histocompatibility complex which is present on WBC, and WBC, this kind of WBC we call APC, antigen presenting cells. Why we are calling it antigen presenting cells? Because it's presenting the exogenous substances, right? Exogenous substances. So in this case, WBC is acting as a antigen presenting cell. In some cases, there are a dendritic cell who will act as a APC, antigen presenting cell. So they are presenting this antigen with the help of MHC molecule, and MHC molecule in this case is MHC1. So it will present to where? It will present to cytotoxic T cell. In T cells, I told you there are receptors that we call TCR, T cell receptors, right? There are on cytotoxic T cells, there is another proteins that we call CD8. CD4 is on helper T cells, and CD stands for cluster of differentiations. And if you remember, I told you not this much signaling is required to present the antigen. There is a co-stimulator signals is also required. So there is a co-stimulator proteins as well. So that will help to present to do the complete process of presentations of these proteins to the cytotoxic T cells. Once it will present it to the cytotoxic T cells, and cytotoxic T cells has identified this as exogenous substances, then what will happen? Then intracellular signaling is going to activate. Once it will be attached to the external parts, so it's going to intracellular signaling is going to activate, and in that intracellular signaling, what's happens? There is a inside the cell there is a nucleus. So that signals will reach to the nucleus, and nucleus there is a transcription and translation process will going on. So transcription is a process DNA to RNA, and translation is RNA to protein. So your protein will synthesize. So protein in this case which will synthesize is interleukin 2. IL-2, interleukin 2. So this interleukin 2 will be released by the cytotoxic T cells when your antigens is presented or your exogenous substances is presented and presentation is complete. So in response to that, what cytotoxic T cell is doing? They are doing the transcription and translation process, and by this process there is a interleukin 2 is released. This interleukin 2 released by these cytotoxic T cells has its receptors on the same cells, right? So interleukin 2 will attach to its receptors, and receptor is present on the same cell which has released it, and this kind of signaling we call autocrine signaling. So it will attach to it and going to the process of mitosis, and your T cells will be increased in number, and that we call process we call clonal expansion. So if someone asks you what is clonal expansion, clonal expansion is a process in which cell will divide in response to whatever the exogenous substance is. Normally they will not going through the process of clonal expansion. When there is a stimuli, then these cells will goes under the process of clonal expansion. Mitosis will happen, and your number of cytotoxic T cells will increase too much. The increased cytotoxic T cells will do the release of lot of cytokines, right? And these cytokines, released cytokines, will going to activate your B cells. There are B cells as well, right? T and B cells makes your adaptive immune system. So these B cells have also a B cell BCR. In T cell there is a TCR, T cell receptor. In B cell there is a BCR, B cell receptors. So these cytokines will bind with BCR, right? And after binding, these B cells will be matured into plasma cells, right? That's what are the plasma cells? Plasma cells are the matured B cells. So it will be matured to plasma cells, and plasma cells will do the production of antibodies. So in this case, the antibody which will be produced is IgE. We are talking about asthma, IgE. So these reactions we also called IgE mediated hypersensitivity reactions. We also called these type of reaction is type 1 hypersensitivity reaction. So asthma is type 1 hypersensitive reaction. So these IgE antibodies will be produced in response to it, and these IgE antibody have a receptors, and where it has a receptors, it has a receptors on mast cells. So mast cells have a receptors for IgE. Got it? So now as I said, 200 students have visited the garden. They have exposed to the pollen. Out of 200, 190 students, what happened in their bodies? The WBC has detected it as exogenous substances, and through the process of phagocytosis, these antigen will be cleared off from the body. But unfortunately, in 10 individuals, what's happening? These signaling has been activated, and due to these signalings, what happens in their body? Now they have a mast cells, but mast cells are overloaded with IgE antibody. In normals, there are a mast cells is there in everyone's body, right? But they are not loaded with IgE antibody. So now still that 10 persons will not get any hypersensitivity reactions, but when they will expose to same pollen, next time again they are planning to go to that garden, they will get into the trouble, because now their body has modified. Now their body has a mast cells which are overloaded with the IgE antibodies, and IgE antibody is produced for that particular exogenous substance. For when next time you will expose to the pollen, you will get the reactions. Got it? You will get difficulty in breathing. That is your type 1 hypersensitivity. Yeah, difficulty in breathing is mast cells. What it is going to do, I will show you in next slide. What will happen? I told you now there is a mast cells. Now these mast cells are overloaded with IgE antibody. Now you got to know how these IgE antibody has been produced and how these mast cells. Now next time when person is exposed to this pollen again, and this process will take around 14 to 20 days. So after 14 and 20 days, you again goes to same garden and same pollen you are exposed. So you will be get in trouble. How you will get in trouble? When this pollen will enter into your bodies, it will be immediately sensed by IgE. So these mast cells, you know, there are an abundance of mast cells in our body. So these mast cells will release lot of chemicals. First chemicals they will produce by degradation of this membrane. So membrane will be degraded. So membrane degradations will result in release of arachidonic acid. Membrane degradations. Phospholipases will activate. So phospholipases will do the degradations of phospholipid into the arachidonic acids. So on arachidonic acids, the two enzymes will act, or two enzymes will convert arachidonic acids into leukotrienes and prostaglandin. So the enzymes which will convert arachidonic acids into prostaglandin, the enzyme is COX, cyclooxygenase. So prostaglandins will be produced. The enzymes which convert arachidonic acids into leukotrienes, that are LOX, lipoxygenase, and these leukotrienes are strong bronchoconstrictor. So that is the one of the answer to your question. These leukotrienes, which is released by the degradation of arachidonic acids by the lipoxygenase, it will result in it will act on the bronchi and it will do the bronchoconstrictions. Okay. Now second is, their mast cells have a granules and which will store the specialized chemical. Mast cells is also having a granules which stores the chemicals, and that chemical name is histamine. This histamine is also released, and histamine is also a bronchoconstrictor, so it's also going to do the bronchoconstrictions. Then in the nucleus there is a transcription and translation process is also going on, and that will do the release of interleukins, tissue necrosis factors, TNF alpha, and so on. They are like your elastase, proteases, these are also going to activate. So all these are going to trouble your normal breathing process. It's going to constrict your bronchi, and if your bronchi is constricted, you will get difficulty in breathing. So this is your pathogenesis of asthma. Means how to and how to diagnose the patients of the asthma. It depends upon symptoms. Sometimes we said that कि डॉक्टर के पास गए, अभी मैं बैठा ही था, मैंने बताया भी नहीं और डॉक्टर ने फटाफट दवाइयाँ लिखना शुरू कर दी. Because when you are going to the doctor, sometimes some disease have such kind of symptoms, without saying anything doctor can sense that what kind of disease you have. जैसे आप आए, आप बोल रहे थे कि डॉक्टर साहब मुझे ना सांस लेने में दिक्कत होती है. इफ़ यू आर नॉट गोइंग टू कंप्लीट द सेंटेंस, so that will say that you have some problems with bronchi, right? You are taking the breath between. आप एक शब्द बोल रहे हो फिर सांस ले रहे हो, that means you are suffering from severe asthma. आप एक शब्द डॉक्टर फिर सांस भर रहे हो, फिर बोल रहे हो, so you will get sense that it is this person having the patients having a asthma, right? Now next is, now we have to do the laboratory test. We have to do there is a FE, I hope you knows about, force expiratory volume. We have some spirometers where we have to ask the patients, so you can get to know about whether there is any problems in the bronchi or not, right? So you can got these diagnosis and treatment. Treatment, what kind of drugs we have to give. Another important thing which I forget to tell is, in bronchi there is a control of your sympathetic and parasympathetic system. So that we will cover next, how parasympathetic and sympathetic systems controlling your bronchial constriction. So now we are going to discuss particularly on how parasympathetic and sympathetic systems control our bronchi. So parasympathetic systems, the major neurotransmitter is acetylcholine, and acetylcholine have receptors all over the body, is of two types, muscarinic and nicotinic receptors, right? Nicotinic receptor is further categorized into NN and NM, and muscarinic receptors is further categorized into M1, M2 and M3, that we call muscarinic receptors. These are the neurotransmitters which is playing a role in the parasympathetic system. Acetylcholine and acetylcholine have a receptor all over the body, muscarinic and nicotinic. So next things, where these receptors are located. So the nicotinic receptors, this receptor NN and NM. So the NN is located in the autonomic ganglia, NM is located on neuromuscular junctions, M1 receptor is on gastria, M2 is on heart, M3 is on smooth muscles like bronchi. So we are discussing about bronchi, right? Bronchi, uterus, all smooth muscles have a M3 receptors. So I told you earlier, receptors are of four categories. Receptors can be your ligand gated ion channels, receptors can be GPCR, receptors can be nuclear receptors, receptors can be your enzyme kinase linked receptors. So these are of four types of receptors, right? Ligand gated ion channel receptors, GPCR, G protein coupled receptor, nuclear receptor, enzyme kinase linked receptors. So next thing which you have to know is which category of receptors these receptor belongs to. So these muscarinic, all muscarinic receptors belongs to GPCR. these are GPCR, G protein coupled receptors, right? So G protein coupled receptors, if you remember, I told you in G protein coupled receptor there are 3 isoform of the G proteins, that are the GI, GS and GQ, right? If your ligand is going to activate GI, so effect will be depressants, means it is going to depress that particular muscles. GS is stimulatory, GQ is also stimulatory, but it is going to produce the effect by the activation of IP3 DAG pathway. So now in bronchi there is a M3 receptors, and these receptors belongs to GPCR, and under GPCR it's going to GQ. So GQ IP3 DAG pathway, so ultimately effect will be bronchoconstrictions, right? Now bronchoconstriction, so you know, if patient is suffering from asthma, so these parasympathomimetic drugs will be contraindicated. Why it's contraindicated? Because person have already the bronchoconstrictions. By giving such kind of drugs which will activate your parasympathetic systems will worse the case, right? But now goes to the sympathetic system, how sympathetic systems control your bronchi. So in sympathetic systems the major neurotransmitter is adrenaline or non-adrenaline, right? So these adrenaline and non-adrenalines have a receptors all over the bodies, and these receptors are alpha and beta receptors, right? Alpha receptor is further categorized into 2 types, alpha 1, alpha 2, and beta is of 3 types, beta 1, beta 2, beta 3, right? Alpha 1 receptors are present on your blood vessels. Alpha 2 receptor is present on presynaptic, it acts as a brake to the sympathetic system, and beta 1 receptor is present on heart. Beta 2 is on your smooth muscle, beta 3 is on adipose tissues, so beta 2 is on your bronchi. So these beta receptors and alpha receptor, as well as alpha and beta receptors, all these receptors belongs to GPCR, but their isoform are different. The alpha 1 there is a GQ, right? Beta 1 there is a increased CMP. B2 is also the increased CMP. Increased CMP will be happens due to activation of GS form. GS will going to activate your adenyl cyclases. If you remember, adenyl cyclases will do the degradation of ATP into CMP, and increased CMP in the bronchi will do the bronchodilation. So what is the conclusion is, if you are going to give sympathomimetic drugs, that will be helpful in the asthmatic patients. So that's why the drugs which are available in the market for the management of asthma are beta 2 agonists, because more you will activate the beta 2 receptors, more bronchodilations will happen. So if you see the compositions of these inhalers which we are using in the asthma, you will find these are the beta 2 agonists. These are your formoterol, salmeterol, these kind of drugs which results in the bronchodilation by stimulation of beta 2 receptors in the bronchi. But if you are giving sympatholytic drugs, so sympatholytic drugs can worse the case. Like suppose someone have sympatholytic drugs we are giving to the hypertensive patients. So if someone have a hypertension with asthma and you have given the beta blockers, so and non-selective beta blocker, so it's going to block beta 1, beta 2 as well as beta 3. So it can worse the case. It can result in more bronchoconstriction and asthmatic attacks can be worse. So conclusion is, parasympathetic systems will result in bronchoconstrictions, sympathetic system will result in bronchodilation. So there is a balance. Thank you.